Welcome to the Rural Minds Connections webinar series. My name is Julie Lux, and I am the Vice President of Communications at Rural Minds, and also your moderator for tonight's session. So it is a pleasure to have all of you with us this evening. We think we have a really fascinating discussion in store. But first of all, as we begin this evening, we want to say thank you because this is, we understand, a record attendance tonight. So we're very happy to have all of you with us, but we also want to say a very special thank you starting out to the sponsor of this evening's webinar, that is Janssen Neuroscience. So very warm appreciation to the good folks at Janssen, and again to all of you for being with us tonight on this fourth and final in our 2023 series. Now, since we have such a great attendance tonight, some of you may not be as familiar with Rural Minds, so I'm going to take just a second to tell you a little bit about Rural Minds, which is a 501(c) nonprofit organization. It was founded in 2001 by Jeff Winton, and it was all started because of the impetus of a personal tragedy in Jeff's life and in his family's lives. And rather than me telling you the story, because I can't tell it as eloquently as Jeff does, I would encourage everyone to take just a few minutes, go to the Rural Minds website and watch Jeff's story and learn about how Rural Minds all got started. But also, I did want to tell you that the organization's mission is to serve as the informed voice for mental health in rural America and to provide mental health information and resources just like tonight's webinars. So couple of things that we always like to talk about at the very beginning, and that is we are very respectful of everyone's anonymity. We know that this can be a very sensitive subject, and some of the stories and the information you will hear is certainly can be that way. It can be very emotional for folks. So your anonymity is very important to us. The names of the people who are watching this evening will never be shown, and you will never be seen in any way. The only folks that you'll see will be those of us who are participating in tonight's webinar. However, that does not mean that we do not want you to participate, and we would like you to participate by asking questions. There is a question button on the Zoom screen, and you can provide us questions, which my great and talented colleague Adriel McMahon will curate, and we will ask those at the end of our speaker's presentation. But we know that in rural areas there are challenges, but there are also some benefits to support for people who are dealing with mental health issues, whether it be their own or their family members. And our first guest tonight has experienced just that type of situation. And I think it's appropriate that we have Chrisa Hickey talking with us this evening, because this is National Family Caregivers Month, and Chrisa has been a caregiver to her son who has schizophrenia. So she will be telling us her story, but we also are delighted tonight to have Dr. Monica Taylor-Desir with us. And Dr. Taylor-Desir is a community psychiatrist at the Mayo Clinic, and she's going to tell us a little bit about herself and help to ground us on a little bit of information about schizophrenia and about its treatment. So with that said, I'm going to cede the floor to our very knowledgeable guest this evening. And Chrisa and Dr. Taylor-Desir, as we like to say in video production, it is your show, ladies.
Thank you, Julie. I guess just going to introduce myself a little bit. My name is Chrisa Hickey. I live in Northeast Wisconsin with my husband, and close by us, about 1.5 miles away from us, is our middle child, Tim. Tim is 29 years old. He was diagnosed with childhood onset schizophrenia at the age of 11. At the time he was diagnosed, we did live in the Chicago area, but as he became a teenager and as he progressed through his illness, we realized moving back to my husband's hometown in Northeast Wisconsin was probably a better environment for him than Chicago, So we have lived up here full time in our town of 345 people for about 6 years.
Good evening. My name is Dr. Monica Taylor-Desir, and as was mentioned before, I'm a community psychiatrist currently working at Mayo Clinic in Rochester, Minnesota. But prior to coming to Mayo Clinic, I worked for 16 years with tribal and rural communities. I started off working in a community in northern Arizona, which was rural, and then moved to Phoenix, Arizona, and worked with a community for 8 years. And then I lived and worked on a reservation in North Dakota, where I served as their chief medical officer and only psychiatrist. So definitely have been in rural communities lacking access for several years. And now I work as a community psychiatrist doing assertive community treatment, where I go out into persons' homes with severe mental illness and provide care in the home setting or community setting.
Thank you, Dr. Taylor-Desir. And before Chrisa shares more about her story with us, and since she was talking about her son, Tim, who has schizophrenia, can you talk to us a little bit and ground us a little bit on exactly what is schizophrenia and how does it affect the person involved?
Yes, I often look at schizophrenia as a brain disorder that results in mental health conditions. And it's often diagnosed in late adolescence, um, at the end of high school, or as persons are going into college. And you'll see different type of symptoms. We've put them into positive symptoms and negative symptoms. So some of the positive symptoms are things that are there that you wouldn't really see in persons that don't have schizophrenia. So those things can be hallucinations, where you can hear voices that are not there, or you might see things that other people don't see. And hallucinations can also be what we call in mental health as command hallucinations, where those voices are telling a person to do something. A person can also have delusions, which may be paranoid thoughts or beliefs or feelings that some people can read their mind, or that things are being inserted into their thoughts. There can be suspiciousness or paranoia, and there can also be ideas of reference. For example, if someone's watching a television show and they're saying something on the TV, and people may incorporate that is being said specifically to me or referring to me, or something on the radio or a podcast may be referring specifically to them. Behaviors may be odd. So those are positive symptoms. We also look at negative symptoms, which are symptoms that you would think are absent, which should be there. For example, what we call anhedonia, which is sort of a lack of pleasure in life, or apathy, where a person really doesn't care about anything. You might see more of a restricted facial expression, which we call a blunted affect, where people are happy about a topic of conversation and you'll see a person smile, but this person does not, or something that's sad. And people usually will like mirror another person's expression. But if someone has a blunted affect or restricted affect, that doesn't happen. There could be emotional withdrawal or low motivation, and there could also be a slowing of thoughts, which you might see in conversation. You're talking to someone, you expect a response, and that response is very slow in coming. The other symptom that we often see is social isolation. So a person with schizophrenia may have just not wanting to be social and wanting to stay more to themselves. And so we're talking more about schizophrenia, but there are also some mental illnesses that are associated, such as schizoaffective disorder or delusional disorder.
Thank you. Thank you very much for sharing that. So we have a little better understanding of what we're talking about. So now, Chrisa, we're going to ask you to, if you would please join us again. And you've lived, these symptoms are not just textbook for you. This is a situation that you've lived. So if you would be so kind as to share your story and tell us about what you have dealt with your son.
Sure. So Tim is a little bit of an unusual case. Like I said, he was diagnosed at the age of 11. We weren't exactly sure what was going on with Tim. He had been in therapy. He had been having some emotional issues, and ended up in inpatient treatment at the age of 11, where he was officially diagnosed. For some reason, his doctor didn't want to diagnose him before that. And he did have many of these symptoms. So Tim does have hallucinations. He has a really, and in addition to hearing voices, and he doesn't really see too many things, but he does have what we call tactile hallucinations. So it feels like someone's touching him, or he has a feeling of something crawling up and down his arm, which is very unnerving for him, as you can imagine. As Tim moved through puberty, it became more and more difficult with our family because Tim's would grow. He was going through puberty and he was getting bigger, and medication that worked one day may not work the next day as he grows, 3 inches seemingly overnight. And Tim did go into residential treatment at the age of 15 and was in residential treatment until the age of 19. When he came out of residential treatment, he was 6 foot tall, and Tim is biracial. So he had some friends that he'd met while he was in special schools and things like that over the years, and he would want to spend time with them in Chicago. And we were very, very afraid of that type of environment for him. I hate to have him get lost in a big city when he's having some kind of episode or some kind of instability. So we made the decision pretty much about that time that we were going to work towards moving back to my husband's hometown in Northeast Wisconsin. It's a very small town, surrounded by several other very small towns, like many places in Wisconsin are. We currently live in a town with 345 people. The next biggest town, about 5 miles away from us, has 900 people. So not a whole lot of folks up here. But we made the decision to move and change our lifestyle because we felt that a sheltered environment where we also had extended family and friends was going to be a better environment where Tim could potentially be more unrestricted, be less restricted than he would have to be if we lived somewhere that was more dangerous. So, but we did find that while there's advantages, obviously, in that having this close-knit community, there's also some disadvantages of living all the way up here. So it was great that Tim now lives in a community where everybody knows him. We've always been very open about Tim's diagnosis. Tim, I've had a blog since 2009. Tim and I have both participated in. We've both done podcasts and things about his illness. And we were just as open to people here when they first met Tim. It's very apparent when you talk to him. He's got, as Dr. Taylor-Desir was saying, he's got some slowness in his speech. He has a stutter when he gets nervous. And it was very apparent there was something cognitively or mentally going on with him. And we would tell people that he has schizophrenia. And I think that really helped people see schizophrenia in a different way up here. I mean, in the entire county, I'm sure there's more, but in the northern half of the county where we live, there's about 3 people with schizophrenia that I know of. My son's one of them. And it's not very common for people to talk about it. But because we were very open about it, Tim has a whole community that looks out for him. So, which we love. He went off his meds a couple years ago. And before I even realized he was off his meds, I got a bunch of phone calls from people saying, I saw Tim today and he seems a little off. So are you sure? Is everything all right? Is his meds okay? Which is really, really what we wanted. We didn't want it to go the other way where someone would assume he was, dangerous or crazy. So it was really nice. So that's the advantage of living up here. The disadvantage is just, you know, for a lot of people, stigma is alive and well. You know, it's like I said, I know of two other people that have schizophrenia, one of them who's around my age, and he doesn't really have a lot of social interaction. A lot of people talk about, you know, him in whispers because they don't really understand. And his, you know, he was kind of sheltered away when it was found out that he had schizophrenia. And I think a lot of folks, the stigma of having someone with a mental illness in your family is still very prevalent, especially because there's not very much help up here. So our county is very expansive. It's about 90 miles across from bottom to top. And in that 90 some odd miles and so many miles wide, we have one prescribing psychiatrist. Who is in the middle of the county, which is great, but is still a 45-minute drive for us one way to be able to go see a psychiatrist. If we need a psychiatric hospital for some reason, it's in Green Bay, Wisconsin, which for us is an hour and a half away one way. So we are pretty isolated when it comes to clinical help. And so for a lot of people that have any kind of mental health issue going on, whether it's depression or anxiety or bipolar or whatever, we pretty much rely on our primary care physicians for that, who, much like in a lot of places in the country, are just not trained in mental health issues. So, you know, if you need an antidepressant or you need a mood stabilizer for bipolar disorder, your doctor may be prescribing something that they read about, but they don't really have a whole lot of experience with. I mean, I joke with my pharmacist up here, they always keep, Tim is on a medication that is a long-acting injectable now, and they always keep one on the shelf because Tim's the only person that they prescribe to in the entire county. So, so they always know it's for Tim and it's always there waiting for him, which is really nice. But, you know, it can be very isolating, both for a lot of people socially, obviously, and then just being able to find help. If you can imagine, I know there was some statistic before that I read that the average wait in America for a first appointment with a psychiatrist is about 12 weeks, depending on the area. Up here with the one psychiatrist, it can be as much as 6 months. So if you're in a crisis, it can really, really take a long time to get some help.
I was curious, Krista, when you were talking about the fact that there were other people in the area who also have schizophrenia, did you find that through your openness to talking about it, that maybe those people were also a little bit better understood and accepted as well?
I think it's a little bit different in the fact that their families, either they don't have, one of them doesn't have too much family left around. And the other person, really, the family still isn't very, they're still very, I don't want to be say ashamed, but they kind of hide him away like he's got an issue that they want to try and deal with. And I think that we have a better chance of influencing how parents of the children in the area, because we have one school that serves a lot of the towns around here. I've done some volunteer work with United Way here. We've actually set up some counseling, at least just counseling in the schools, more so than just your standard, you know, school counselor who's your guidance counselor. And it's going year round now. We did some fundraising with United Way so that if kids who needed help with depression or anxiety and needed to talk to a counselor didn't have a gap, not only did they have it in school, but there was not a gap when there was a summertime. So the counselor's there, you know, whether I think it's every other week right now in the summertime. But again, we have to have people drive up here from as far away as Green Bay and Appleton, which can be an hour and a half to 2 hours one way to help us provide this service. So, but to answer your first question, I think we have a better chance with the teenagers and the young people in the county because their parents, a lot of them have interacted with Tim. Tim is out and about in the community quite a bit. When he's very stable, he's actually pretty social. So he likes to get out and about, and people seeing Tim and knowing about Tim, I think helps them feel better when their child expresses an issue.
So Tim's helping to break down on the stigma himself. That's awesome.
He
Doug,
is.
I'm going to ask the doctor to join us here too, because Dr. Taylor-Desir, when you're out talking with your patients, have you seen a change in the way that people are accepting individuals that have schizophrenia, bipolar, some of these other mental health challenges?
I think you're on mute, doctor. Yep.
Thank you. I think it's still a challenge for people to accept mental health diagnoses of schizophrenia and bipolar disorder. And I think within families, it can it can be unique. Some are very accepting and supportive. But when working in rural communities, it is, I'm going to say it's a lot of work for the caregiver to find those resources and find that support. I have had family members that are just the biggest advocates for their children and their loved ones, but also thinking about what Chrisa had stated, it can be a long drive or long travel for folks. So I worked in communities where it was like a 2-hour drive, and we were able to institute some telehealth services, but that was prior to COVID. So now it's more ubiquitous and in the community, but it was really difficult. Um, I wanted to mention, Krista, you were saying that your son was diagnosed early at 11, and I will say that psychiatrists definitely are very hesitant to diagnose early because, unfortunately, when we talk about stigma, also in the community, there can be stigma within the medical community.
Absolutely.
So we don't want to put schizophrenia on a chart and then it just stays with someone, when it's maybe not the most accurate diagnosis.
Yeah, absolutely. I mean, talked about how the doctor he had wouldn't give us a diagnosis. Um, when Tim finally went into residential treatment, is because he had attempted suicide. And so in the hospital, the psychiatrist in the hospital is the one who said he has all the hallmarks of it. And honestly, we didn't believe him because we'd never heard of a child who'd had, that young, who'd been diagnosed with schizophrenia. But and it was basically it was kind of a working diagnosis until he was about 14 or 15, and he really was showing kind of the classic signs. So I understand that. I also worry that the problem that a lot of parents that I've talked to have said is, if a doctor can't tell me what it is, or won't tell me what it is, or is worried about labeling my child, it makes it that much harder for me to get help. Because a lot of times, if you're trying to get social services or you're trying to get insurance coverage, if you don't have a diagnosis, you don't get it. So by a doctor trying to do what they think is the right thing for the child and not label them for life, with schizophrenia or something similar, what you're really doing is preventing that child from getting extra IEP services at school, extra support services, any kind of community-based services that they could be offered. And it becomes, everything becomes a fight.
Right. And that's such a good point. And I wanted to talk a little bit about treatment. And you had mentioned residential treatment, and we talk about outpatient and also thinking about how far you have to drive. And then, what exactly is residential treatment? That means that someone is living there and going to school, and it's almost like a hospital setting, but it's where they live and get treatment and go to school, and hopefully it was a good experience. I know when I worked with adolescents in tribal and rural communities, I was always really concerned about that education piece.
Yeah, it's honestly, the education was, we were trying to keep him alive. So for us, education was the least important part. And I will say, Tim ended up being, a super senior. And for those of you who don't know, someone who has a disability most states can go to school until the day before their 22nd birthday. So Tim did do that. And he has a certificate of completion, not a diploma from high school, because he did lose a lot of cognitive ability. Tim was floridly psychotic from God only knows what age until he was about 17. So, let's say it's 10 years of complete psychosis. he was not, you couldn't educate him anyway. So it became more of a process of him learning. And what he really did get out of residential treatment, and what made it a good experience for us, is he got a lot of coping skills and life skills that he was able to use to, how do I manage my own symptoms? How do I learn to advocate for myself? And we continue to reinforce that all the way into his, through his 20s.
I want to go back for just a second, Chrisa, to, as a parent, what were the signs that led you to become concerned that maybe there was something going on with Tim? I know you mentioned the kind of the apex when he
Oh boy.
sadly attempted to take his own life, but what led you to be concerned initially?
Well, it's like I said, Tim's kind of an unusual case, but Tim was one of those kids who didn't talk when he was a toddler. He was always kind of in his own world, and was very, very easily agitated, to the point of rage. So not your typical tantrum at 4 and 5, but raging, screaming, literally could pick up furniture and throw it type of rage. And when he started kindergarten, we said to his kindergarten teacher, we have some concerns about Tim. We've talked to our pediatrician, and pediatrician has an older sibling who talks for him, whatever, it's typical toddler, issues. But if you think there's an issue, would you call us so we can, go back to our doctor? And she called before the end of the first day. So, Tim had all kinds of issues, whether it was language-based issues, understanding, could not read anybody else's facial expressions, which I think one of the things that Dr. Taylor-Desir was talking about, he didn't understand cause and effect very well, even for small things. Like if I push a child off a swing and the child cries, he would go to comfort the child, not understanding why they were crying. So he had some beliefs, like there were certain places in the school he didn't want to go because he was afraid of them, or he thought they were dangerous. There's some kind of delusion going on. And we started all kinds of testing. We literally did not have a diagnosis of anything other than, emotional disorder, NOS, not otherwise specified, which are my 3 least favorite letters in the English language. But he had lots of NOS diagnoses until he attempted to take his life. And at that point, his psychologist and psychiatrist that were treating him outpatient talked to the inpatient psychiatrist, and they agreed that what they had been trying not to tell us was that they thought he had schizophrenia. So it's a lot of little things that piled up.
Oh my gosh. And so that prompted you to make the shift. How long did it take you to kind of come to the decision that maybe the best thing to do would be to get to a different environment?
Well, it didn't take long. So, for us to ingest it, took longer than it should have. Here's bad parenting moment. We took him out of the hospital, the inpatient hospital, when we were told he had schizophrenia, because we didn't believe it. And 6 days later, he attempted suicide again. So we're like, okay, obviously we're the problem. It's not the doctor that's the problem. So we started figuring out what we need to do for our son. When he became a teenager, and his later teen years, really like 17, 18, 19, he was a very large Black man. And he was very, like I said, stable by that point, was very social, and wanting to spend a lot of time, like young people that age do, in the big city with his friends, whether it's, going to restaurants or hanging out at the big park and, going to, ball games. And I was afraid that he would just exhibit enough signs, or he might potentially have an issue if he was stressed out enough, where someone there might be police involvement. I was literally afraid for his life. So we decided that smaller and contained was better. Even in Lily White, Northeast Wisconsin, we felt that it was a better place for him. And he does stick out here like a sore thumb, I'll tell you. But he is widely known, and we call him the unofficial mayor of the town, because he knows everybody. He has an electric bike now. He rides all over town and waves at everybody, and they all wave back. And it's a much better environment. He has a much more normal life here than he ever would have in the big city, just because I was too afraid to let him have it in there.
Yeah. Dr. Taylor, does this story sound familiar?
Oh, yes. So, Krista, there are several things that just resonate from your story. Um, I think families can be really hard on themselves when trying to understand what a mental health diagnosis is. Is it really schizophrenia? Is it really bipolar disorder? And
Yeah.
I think lots of people struggle going down that road, and so I don't think it's a bad parenting moment at all. It's really what I think about is how much education did our healthcare system give you? How much did you know about the illness?
Not a lot. I had to go find it. I mean, the first thing so I told you our psychiatrist didn't want to diagnose him. When he finally got diagnosed and we saw him, his advice was to surrender our parental rights to the state so Tim could get the right treatment, which unfortunately, a lot of parents of kids with mental health issues are given that advice. And some of them, that's the only way they can get it,
Right.
which is awful. We absolutely refused to. I wasn't going to give my kid away. He wasn't defective. He was my kid. And obviously we didn't do that, and we went a couple other directions, and now I'm happy we did. We happy that we stuck it out, even though it was incredibly difficult and hard on our whole family.
I think the other thing that really resonates is um, not only having a son that is a person of color, but just having a person that's related to you that has a mental illness and fearing that they will not be treated appropriately by law enforcement.
Yeah.
And I've had lots of challenges with that over my career. I would say I'm an older doc. I went to my 25th med school reunion recently, so I've been out for a while. But lots of families fear that interaction with law enforcement, who doesn't always have the education on how to interact with persons who need healthcare.
Right. So for him, I felt it was a double whammy in the big city, basically.
Yeah.
Yeah.
I can imagine. Well, we are starting to get some terrific questions from the folks watching, so I'm going to jump in here. We do want to get back to treatment again in a few minutes, but these are such great questions. I'm going to start here. One of the things, and Dr. Taylor-Desir, you had talked about, was this whole idea of the use of telemedicine, telepsychiatry in rural areas. How
Yes.
helpful is this? I mean, we know that roughly 28% of people in rural areas don't even have dependable internet service. So how effective is it if somebody can get it?
It's very helpful. And I'm going to say that when I first started working in North Dakota and I got some residents to come on the reservation, which is really rural, to provide care, what I was offered by the university is they can come once a month and then you can have telehealth for the rest. And I was just thinking, nobody's going to do telehealth. And my patients really liked it.
Oh,
But the thing is, they came into the clinic where we had the infrastructure to have telehealth. So we weren't really doing telehealth at home. So I think it has really increased access, but also on the flip side, we also know that in rural areas and tribal communities, there is not the infrastructure
Mm-mm.
for you to do telehealth from home, usually.
Right. We have about 40% high-speed internet coverage in the county. So we've gotten some grants from the state and from the federal government, and wires, and cables and things are being run. But it became very apparent over COVID that we're an internet desert, so to speak.
Right. Right.
understood. It's not it's getting there, but from
It's getting
what you
there.
were saying, not there yet. Kristen, question is, was Tim diagnosed with any other mental illnesses prior to schizophrenia, like depression, anything else?
Oh yeah, sure. First, it started with, and again, my three least favorite letters in the English language. It started with pervasive developmental disorder, not otherwise specified, when he was about 4 or 5. Then it went to an emotional disorder, not otherwise specified, bipolar with psychosis, And then they got to schizophrenia. So the doctor was talking about some kind of bipolar disorder, and maybe there's some psychosis to it. And her notes, when we got the copy of her notes, finally it said bipolar psychosis. So he wouldn't tell us, sorry, him, he wouldn't tell us, but he did write it in the notes. So yeah, there was tons, and it's not unusual. The younger, probably, I would think, and doctor, you let me know if I'm speaking correctly, but I think we did I did a blog post about this once, where autism and severe mental health for children under the age of like 12 have overlapped like 80% symptom wise. So it's really, and this is why I can see why you don't want to saddle a kid with something like a schizophrenia diagnosis unless you're sure, because so many things overlap and it's hard to
Right.
tell.
Right. And as you know, as they're developing, then you're seeing a clearer picture. But yes, I hear you when you say, not otherwise specified
NOS, yeah,
is like the catch-all of we're not really sure exactly what it is.
yeah,
Oh
exactly.
my, oh my, but there's a level of frustration there and not knowing, because you want to help your child. Someone else has asked, does Tim have siblings? And if
Yeah.
so, do they display any tendencies toward mental illness?
Good question. So Tim's adopted,
Mhm.
and Tim has two adoptive siblings. So those, if you're talking about genetics, that doesn't really count.
Mhm.
Tim has two biological half siblings that he doesn't have a great relationship, like a very familiar relationship with them, but he knows them and knows who they are, and they have interacted. One has bipolar disorder, and one has cognitive disability. So they do have some similar brain issues going on. They're all adults now. They all have similar brain issues going on. And Tim has a biological grandfather who was bipolar.
Is that typical? Is that something you see a lot of, Dr. Taylor-Desir?
Yes, yes. So so schizophrenia, affects 1% of the population. But between schizophrenia and bipolar disorder, there's a strong genetic link. So definitely, would see family members with bipolar disorder or schizophrenia or other cognitive issues.
Going back to symptoms for a minute, is self-harm typical with people with schizophrenia?
So it is. And when I say self-harm, I'm talking about suicide attempts.
Mhm.
So we say suicide attempts. The other category when we say self-harm is persons that may cut themselves but are not intending to end their lives. But there is a high rate of suicide in schizophrenia and bipolar disorder. So it's something that as physicians and psychiatrists, we really look out for.
Doctor, another question for you here. It says, besides access to resources, what are some of the other challenges to providing mental health care in the rural community?
Right. Thank you. So, definitely there are many challenges. And when, first is like, well, if I see this person in the office and if I am in a more urban area, I'm thinking about all of the community supports that are available. So I'm going to say like NAMI meetings or, support groups or vocational rehab. And when I was working in rural communities, they didn't have all of that. Or day treatment programs, let's have this person go to a place where other persons that have severe mental illness are and get some type of group treatment from maybe 9 to 3. Didn't have that access. The other is we talked, I think Chrisa and I had talked earlier about um, making sure that there's a good pharmacy there that knows the medications that this
Oh
person
boy.
is taking, or if this person is taking medications that needs lab monitoring, that the lab, they can get to the lab, we can get those results back. And when I practiced in North Dakota, and there was a medication where a person had to get their labs drawn, their blood drawn weekly. and then I had to get the results back, and the pharmacy needed to get it before they could give the medicine. I mean, that whole system and that structure is a challenge. Um,
It's even still a challenge for us. I mean, so Tim was on that medication at one point, and boy, trying to educate a pharmacy that's never heard of the medication or even diagnosed, given out any medication like that before is rough. But so Tim now is we switched him to a long acting injectable. So he only needs an injection once every 3 weeks, which is great, except that the only person that will give him the injection is his prescribing psychiatrist. His local primary care doctor, who is 5 miles away, won't do it because he didn't prescribe it. And the pharmacy doesn't have anyone who can do it. They're not licensed to do it. So we have to drive through every 3 weeks, 45 minutes one way. Tim is in the office for 45 seconds and gets a shot.
Yes.
And then we, do our grocery shopping and, run our errands because that's where the big store is too. And then we drive home. So just for him, that's another thing as far as, other issues that you have to think about if you have medication that needs monitoring or needs some kind of that needs to be administered to the patient. It can be a chore.
Well,
and
since
even
no, I'm sorry, doctor, go ahead.
I was going to say, even with that, definitely, I think more about the benefits of long-acting injectables. For persons that have a hard time organizing, remembering their medications, remember to take them, or when their symptoms are increasing, or they feel like, man, I'm better, I don't need this anymore. And they stop taking the medicines for 2 weeks, and then then they decompensate really quickly.
Mm-hmm.
Really like to encourage long-acting injectables, and it's a wide range. So some of the long-acting injectables you have to take every 2 weeks, and some can be out as much as every 3 months. So it's a long range, and I think there's a newer one that is every 6 months.
Mm-hmm.
So we get doctors are excited about that.
Patients are too. Tim likes it a lot better.
I can imagine. Since we're talking about medications, Dr. Taylor-Desir, kind of give us a little bit of an overview of the different treatment options. We talked about the long-acting injectables, which sound very attractive, but what are some of the treatment options? And typically, is it a trial and error process to find out what works best for a certain individual? But before you answer that, I just want to say thank you to everyone that's watching this evening, because we are getting some terrific questions. So please keep those coming, and we'll get back to them in just a minute. But let's talk just a little bit about those treatment options, doctor.
Right, definitely. We'll start off looking at medications to target symptoms that that I mentioned at the beginning of our webinar. So if we're looking at symptoms that what we call psychosis, maybe hallucinations, delusions, paranoid ideation, we may look at antipsychotic oral medications. And usually that's where you'll start to make sure that a person can tolerate it, that the side effects aren't awful for that patient. And every case is unique. So working with that, with a person working with their physician and their treatment team will figure that out. But usually if we can get someone stable on an oral medication, I will often offer the option of getting a long-acting injectable. So again, what we talked about of not worrying about having to take a medication every day. Some people don't want to talk about getting a shot. They don't like needles, so that's not going to be an option for them. So those are the main ones we look at as oral medications, long-acting injectables. Also in treatment, like total treatment would be also having some type of therapy, whether it's a supportive therapy where you're talking with somebody or having a peer support. When we talk about peer support, that's someone who's had a lived experience of mental health conditions. And then we also talked about residential care. And usually residential care is going to be for our adolescents. We don't see a lot of residential care for adults. So you may, in Minnesota, we have like community behavioral health hospitals, which is about a 30 to 90-day stay, but it's not going to be super long term.
But there are, and again, as you were saying, this is a process, consulting with the physician that are taking care of the individual to find that right treatment for that particular person. Thank
Right.
you. Thank you for that. Let's we're gonna go back to our questions here. The question came in, if you suspect a child, family member, or even yourself of suffering from a long-term or from a mental illness, who do you go to first in a rural area for help? Is it the primary care doctor? Is it better to travel to a larger city? Where should someone start if they're concerned about themselves or a loved one?
Right. Usually we'll say contact your local physician, and it's usually going to be primary care. So that also brings up the importance of collaboration of a primary care doc with a psychiatrist or with a medical society that can sort of connect them to psychiatry. In some communities, they have what they call they call it echo, and I can't remember what it means, but it's sort of like a hub and spoke kind of
Okay.
model where they'll do lectures, and usually it's for rural communities, and lectures on opioid management, mental health, and people log in through through Zoom and have questions, and then can get some of that information.
Well, I'm going to give a little plug for Rural Minds here and for the Rural Minds website, because we have a great deal of information already on the website, and more is being added all of the time. So one place that people can go to at least get a start is to gathering all that important information is ruralminds.org. So that's my commercial for the moment. But to get back to the questions, I should have asked this one before the last one, but Chrisa, how long did it take to find the right medications for Tim?
Oh, Lord. Well, you have to remember Tim was going through puberty as we were going through all this. So it took, like I said, he was floridly psychotic until he was about 17. So he was diagnosed at 11. So there was trial and error on medications. I think he's been through, at one point I cataloged it at one point. I think he's had like 31 different medication trials, combinations. And some of them stopped working because he grew. Some of them stopped working because he couldn't tolerate them. He couldn't tolerate the side effects, so it wasn't a good option. It could be real trial and error. We didn't have, when Tim was first diagnosed, there was no, I know there are some tests now you can do to see if there's certain medications, and you probably know about that much better than I do, how if they are matched for you on a biological level, but we didn't have that when Tim was young, so we never have been through that.
Right. So there are some genetic testing to sort of see what you metabolize or what your body is more responsive to. They can be helpful. They're not always the magic wand that we think it is. Even though, like, okay, you have a list of 4 medicines that says it will work. We don't know until we actually try the medication with that patient.
But it's so wonderful that there are medications now that can help people. So it's probably, I would say, Chris, has probably been worth the effort to be able to see Tim.
Yeah, it is. I mean, it's worth the effort to have him here. I mean, as we're going through all that, I mean, it's very difficult. You talk about education. We talked about that a while ago. When Tim was going through the high school years, we were just trying to keep him alive. And different medication trials were easier and harder at that effort. So
I can imagine. Well, it's thank heaven that he has you.
Well, every kid, whether they're still a kid or an adult with schizophrenia, I'm hoping that they have a loving parent. I'm lucky in that I met a lot of moms like me online, and we were able to band together and really support each other and help each other and share information.
Well, and again, this is where the caregiver, there's this caregiver month, and this is where the caregiver is so critically important in the process. But I want to get a few more questions in here from, because this is great. Thank you everyone for these terrific questions. The question for you, Dr. Taylor-Desir, this is interesting. What is the best way to help adult family members with schizophrenia if they're in denial or unwilling to get help? Is that something you see very often?
Yes, and that's really, really difficult. I feel for persons that are in that situation. First, I talk about at least will they go to their primary care provider and see if we can talk a little bit about that through primary care. Sometimes it's where they are willing to be seen. So, is there a walk-in crisis center? Is there a counseling center that would be helpful? Then you want to engage sort of some of their support system. Is there a friend? Is there a pastor? Is there someone that can help talk to them about getting some help? It's really difficult because I don't want to, and I never do want to go immediately to, let's see if you can commit them into the hospital. That is really hard, and it's different between states. So I've practiced in 3, 4 different states since training, and all of them are different. Some family members can go and petition the court, and police will pick them up and bring them in for an evaluation, and some you need more than that.
Yeah. But maybe sometimes you were talking about finding the pastor or the someone else, maybe just someone outside of the family can sometimes help more than maybe the people in the family are too close.
Right. Or sometimes, they still, people want to hide those symptoms from their family members, especially whatever messages they feel like they're getting, like this is acceptable or it's not acceptable, or I'm disappointing a family member.
Interesting. And I can imagine. Very, very true. Chrisa, people are interested in Tim. A question is, what is the long-term prognosis for Tim's illness with medication? And the side question to that is, do you think Tim is happy?
That's a good question. So I've asked him that, and we actually did a podcast last year where somebody asked him that. And Tim will tell you that he is as happy, he's content. So there's certain things about his life that he wishes were different. Tim's unable to hold a full-time job. He sometimes wishes he had a job that he could go to more often, that he was able to handle that. Tim does not have a girlfriend or any prognosis for one. And of course, for him, he feels like that's a hole in his life. But Tim has lots of friends that he spends a lot of time with. And like I said, we've made him as independent as possible. He lives in a little apartment, a subsidized apartment about 2 miles away from us. So he has his own space. He's got his own transportation. He's got his own friends. And we're here for him for support. I keep looking, by the way, over at my phone because he's texting me. Tim, I am Tim's primary support person, so he texts me about 500 times a day. But it's I think he's as happy as we can make him. And right now he's happy enough that he'll tell you that he's content. But yeah, I know people meet Tim and they love Tim. They really do, which is nice because, like I said, it's really weird that the most outgoing and social person in our family is the one with the severe mental illness.
Oh my God.
And it's funny too, because when he's not stable, you get that flat affect. Don't talk to anyone, isolate, the whole thing. But when his since he's been on the long acting injectable, and it's been several years now, he's much more social. In fact, my husband was with him this afternoon. He said he's been in a really good mood for like 3 weeks. So
that's a good sign for any of us to be in a good mood. 3 weeks. I think that's probably good for any person. But as we're getting close to wrapping up here, Dr. Taylor-Desir, anything else that's really important for people to know and understand about schizophrenia and potentially just about the unique challenges and how to find help when you're in a rural community? It sounds like there's, from what Chris is telling us, there's certainly advantages as well as disadvantages to being in rural America.
Right, right. And I think the biggest thing is trying to use the internet if you have access as much as possible. Now we have more support via Zoom or webinars or how people connect on social media, and just really looking for that support as caregivers and as persons with mental health conditions. There are more support groups and family support groups out there that are available via internet.
Yeah, NAMI has some great peer-to-peer online support groups.
Absolutely. Okay, Chrisa, anything else you'd like to share, especially as a caregiver? What would you say to other caregivers who may be, dealing with any mental health challenge with someone that they love?
Yeah, I usually tell people when they ask me two things when you first get a diagnosis, especially, and that's that if this is your child or spouse or sibling, it's not your fault that this person has a mental illness. It's not, you didn't cause it. It wasn't, this is not a product of your making. This is just something that you've been challenged with. So there's the first thing. The second one is find someone, and I don't care if it's a therapist, you need to have your own psychiatrist, an online support group. There's lots out there, a neighbor who's very, willing to listen. Find someone that you can truly, truly vent to and is just going to listen. Because I talked about all the different moms I found online when we were going through this. One of the great things about having them is I could go to them one day and say, I really don't like my kid today, and explain and just unload all the things that were happening. And no one ever judged me and said, oh, you can't blame them and blah. No, they just said, let it all out. And having that outlet, you can't, what they say, you can't pour from an empty cup, right? So having that outlet, whether it's your own therapist, which I have had for a long time, or some other support group, is very important.
Well, thanks to both of you so much for your time this evening. Chrisa Hickey, Dr. Monica Taylor-Desir, just wonderful information. And you can tell from the response from our audience and the great questions that we got, how engaged everyone has been in this subject. But thank you for your time. And as we close this evening, I just have a couple of messages to share with our audience. And again, thanks to everyone watching for your time and for your great questions and your participation. That's made this webinar, I think, very interesting and beneficial to all of us. So on that note, we also want to hear your opinions as far as the webinar was concerned. So those of you who are watching will receive a short survey. And again, your responses will be anonymous, but we would love to hear from you, because we know that these responses have in the past generated the subject matter, like the great subject matter that we were discussing tonight. So again, to the doctor and to Chrisa for their great information, to the good folks at Janssen Neuroscience, thank you so much for your sponsorship, and to our friends at the National Grange for their partnership, which is continuing, and we'll have more exciting news about things coming up with the National Grange very soon. So stay tuned for that. And Rural Minds, again, is a nonprofit organization. We rely on the generosity of donors. So if you have found this information beneficial, please consider going to our website, making a donation, but also telling your friends about Rural Minds, telling people who are not aware of the organization, the work that we are trying to do to support the folks in rural communities across the country, and engage with us. We are on all the social media platforms, so please engage with those as well. And that is where you will also on social media find out about the 2024 Rural Connections webinar series. So please watch for that information coming soon. And our very sincere thanks to all for joining us. I think it's been a fascinating evening, and we wish you all a very good night.